So I'll be brave if you're brave. I'll be brave, but only if you're brave.
Good morning, good afternoon, good evening, depending upon where you are chiming in from today. Welcome to the Lung Cancer Living Room. I'm Danielle Hicks. I am Chief Patient Officer here at GoTo for Lung Cancer. And for those of you who may be new to this program, it's a monthly speaker series where we invite key opinion leaders from around the globe to come in and talk about varying aspects of the disease. As you may or may not know, today we're going to be talking about stigma and how we can come together in a global way to try and combat what we know has historically not only hindered process and funding and research, but really burdened those diagnosed with this disease. So welcome again to all of you here today. I don't know if there's a sound issue. Sorry. Today's speakers, sorry for the pause. They'll be able to edit this out. Today we have Dr. Navneet Singh. Huh? Oh. There we go. Is that what's causing? Oh, much better. So now I just have to sit like this for the rest of the program. Today, for today's program, speakers, we have Dr. Navneet Singh, who's a professor of pulmonary medicine, Postgraduate Institute of Medical Education and Research in Chandigarh, India. I hope I got that right. We also have Rachel Avery, who's the Director of Marketing and Communications at the Roy Castle Lung Cancer Foundation in the UK. We have Heidi and maybe Pierre Onda, I'm not sure if Pierre is going to join us today, co-founder of the White Ribbon Project from the United States, and Lauren Pretorius, who's the Chief Executive Officer at Campaigning for Cancer in South Africa. We could not be more thrilled to have these folks joining us today, and I've had the pleasure of having some conversations with them prior to this meeting, and it was interesting to find that although there are a lot of similarities, some of the ways we're combating them are different, and so we're seeing how things that are happening in other countries might actually be replicable in other places. So today's objectives are to really understand the challenges around the world as it relates to lung cancer stigma, the role of patient advocacy organizations and really patients themselves in helping to eradicate this stigma, and how together we can work to humanize this disease. So before we jump into the main program, I'm going to turn it over to my friend and colleague, Daria Stegman.
Hi, thank you, Danielle. And thank you first to our title sponsors, AstraZeneca and Novocure, for their support of the Elcam Coalition. And welcome to our audience around the world. For those of you who don't know us, the Global Elcam Coalition raises awareness about lung cancer and the need for really more research, more screening, more treatment options to improve quality of life and survival. And so we are delighted to be convening our first live event, and we want to thank our Elcam Coalition partner, GoTo for Lung Cancer, for hosting us. I really can think of no topic more pertinent than combating stigma, and I'm looking forward to this conversation. So thank you, Danielle, and thank you to all of you.
Thank you, Daria. And with that, and being mindful of times and time zones that folks are signing in from today, Dr. Singh, I want to start with you, and can you talk a little bit about who you are and what lung cancer looks like in India, or what lung cancer stigma, I guess, looks like in India?
Thank you for having me. And so my name is Navneet Singh. I am a professor of pulmonary medicine and a thoracic medical oncologist, and the faculty in charge of the lung cancer clinic at my institute, which is an Apex Referral Institute in the north of India. And lung cancer, obviously, as is the scene worldwide, is a very important cause of both morbidity and mortality related to cancer. Regarding specifically the topic of today's event, which is stigma. So I will just start by saying that it is not uncommon for us that we are sitting in the outpatient, and before the patient himself or herself comes in, one relative or another family member or caregiver will first come in and tell us that the diagnosis is not known to the patient and we don't want you to tell that. And so that is how it really is, and that is still going on. It is probably reduced over the years with more access to social media, more access to online materials, especially amongst the families which are well educated. But we have a lot of patients who come from lower socioeconomic status, from who are not very well educated, and it happens very frequently that the patient's primary caregiver or immediate family member learns about the diagnosis and does not want the patient to know about it, simply because they feel it is going to affect his or her ability to counter the disease. And we have this request almost, we'll see it in every clinic, at least one or two people coming in and telling us about this request. But well, with time, obviously, it has become much less, and we hope that things like this continue to diminish.
And Dr. Singh, just to kind of touch on that a little bit, so not wanting to tell the person diagnosed themselves what the actual diagnosis is that because of a personal shame, blame thing, or is there actual fear that they will be shamed and blamed out in the community, and that will affect their day-to-day, or both?
So to a large extent, it is also based upon the stigma of cancer in general, that, okay, if you get a diagnosis of cancer, it really means nothing more can be done, and the patient's mental ability to carry on with his or her daily activities would get hampered. In fact, we have occasionally seen patients themselves coming, and we ask them about their performance status or functional status, and it is not uncommon for us to learn that before they got the diagnosis, they were going about routinely, but once they learned about the diagnosis, they stopped going outside and were literally confined to their house. And we have to encourage them that please go ahead and do whatever you can to without overexerting, do what you can to the best of your ability. The other thing is, obviously, even amongst the community, the relatives and even the patients themselves will not really fully disclose it. They will say that, okay, if some other person asks that why is that person not being seen so frequently or is not coming to certain events, they'll say he's not keeping well, there has been some health issue, and not disclose it publicly. So yes, that happens. But as I said, that has come down with time, especially amongst people who are well educated and have access to better educational material.
And Dr. Singh, what is the incident rate of lung cancer in India? Is it fairly high?
So the more common cancer is obviously head and neck cancer in India, but lung cancer is still one of the most top 3 cancers, especially amongst males. In females, obviously, you have breast and cervical cancers, which are more important, but for males, it is important. The issue here is obviously that the mortality from lung cancer is an important consideration even amongst females.
Yeah. So we're still looking at a high propensity, I guess, for lung cancer in India, thereby sort of directly relating to a high incidence of stigma, right, associated with the diagnosis. So, Dr. Singh, are there any organizations, advocacy or otherwise, in India that help support or try to help to combat the stigma associated with a lung cancer diagnosis?
So advocacy till now was still very much at a very nascent stage or in its infancy, but in the last at least 2-3 years, we have come across several support groups as well as organizations which are now actively working in this field. They are not specific for lung cancer as such. They are for cancers in general, but they are also working now in the field of lung cancer, given the increasing importance of both biomarker testing as well as targeted therapies and the much better responses to such biomarker directed treatments.
So doctors are helping. How are healthcare providers helping their patients, the ones that do know, I suppose, of their diagnosis? How are they helping them to combat and cope with the stigma that is associated with it?
So, I did this, giving my example, almost 15 years back when I became a young faculty, that I wrote a patient information booklet in English and had it translated into 2 of local languages. And we used to give this free of cost to every patient who was newly diagnosed with lung cancer. And when their family member or caregiver used to come in and say, please don't tell the diagnosis, I said, okay, we are giving you this small patient information booklet. If possible, please ask him or her to read it. It will really help. It will answer your questions. It will answer the patient's questions, and thereby sort of help in reducing the anxiety as well as the stigma which they may be carrying. And the patient information booklet wasn't a big one. It was very brief, it was very concise, and you could easily read it in like 30 minutes or even lesser. It used to give them an overview of what is lung cancer, what are the various stages, how is it treated, and why is it important to keep hope, why is it important to have access to the most relevant treatment strategies, and discuss them with the treating clinician.
So, by way of educating the people diagnosed, you're in a sense empowering them to become their own advocates and to sort of band together. Is there any opportunity for those people and their family members, their caregivers, is there any sense of community around it, I suppose? And I say that because in the US, looking at breast cancer even as an example and how women banded together and really created this community, we're seeing that here around lung cancer now because, to your very, very valid point, where patients are being educated and empowered to understand their disease, to have conversations with their healthcare providers, but also outside of that clinical space, this community sort of element we've seen have a huge impact here. Is there anything similar to that in India that you know of?
Well, so it's not really in a very structured format, but what I can tell is that the place where I work, which caters to a large patient population, and obviously has for any given outpatient has a lot of people at any given point of time, and there is a long waiting period. So we know that patients and their caregivers often talk to each other and in fact learn from each other from their experiences, and it helps them. So I don't have a way to share the photographs of how crowded outpatients look like, but they have to often wait for hours before they get seen. And during that time, they talk to each other, they learn the other person's experience, learn that, okay, this patient benefited from this type of treatment, and they'll often ask that, can I have access to an oral drug, the targeted therapy, or is that relevant for me? And so in a way, that's an informal bonding which occurs. And I guess once they go back to their native areas and they learn of somebody who has the similar disease, they tend to pass on that information. So we get patients who will come and tell us that I'm coming here because one of my close friends or close relatives was treated under you and did very well, and therefore we want you to treat us the same way. So it's more or less an informal communication channel and bonding.
Great. Well, you're doing a fantastic job. I know that this programming, the Living Room, in particular, when we look at our metrics at the end of the year from a viewership standpoint, we have almost equal the amount of people from India clicking and watching the videos as we do from the US, which is really fascinating to us, and in part because of these conversations that you're having, encouraging them to go out and educate themselves. So thank you so much. Rachel, I want to turn to you. Can you talk a little bit briefly about Roy Castle, and then we'll jump right into what Stigma looks like in the UK.
Yeah, hi everyone. So Roy Castle Lung Cancer Foundation is the UK's leading lung cancer charity, and we're the only charity in the UK that is solely dedicated to supporting everyone affected by the disease, so all types of lung cancer. The charity was founded in 1990 by Professor Ray Donnelly, who at the time he was a highly recognised chest surgeon in Liverpool. And he was just growing increasingly frustrated that by the time he met patients, there was nothing he could do to help because they were coming to him too late. It was too advanced for surgery. So he wanted to do some research into early detection to try and change that. And ultimately, the stigma meant that actually no one else was interested. He couldn't get it funded anywhere, so he decided to do it himself, and that's how the charity was born. It was originally known as the Lung Cancer Fund, and we later became Roy Castle Lung Cancer Foundation when a UK beloved entertainer called Roy Castle went on to develop lung cancer, and it completely shocked the nation. He was very much beloved and still is. He was a non-smoker, and his lung cancer was attributed to playing a trumpet. He was very, very talented, and one of his talents was he was a trumpet player, and he was playing in smoky jazz bars. And he was diagnosed. He went very public with his diagnosis to raise awareness and highlight the fact that anyone can get it. And he ended up taking part in what was called the Tour of Hope, which was a tour around the UK, raising awareness, raising money, and he raised over £1 million, which went towards the first lung cancer research centre. And research has remained at kind of the heart of our charity. We've funded over £30 million into early detection and patient experience, and that's actually laid the foundation for the newly implemented screening programme for lung cancer that the UK has now been got the green light for. And then the charity also offers a wide range of support services, and we do a lot of outreach work to obviously raise awareness and improve conversations, challenge stigma, challenge misconceptions.
I love it. So what does lung cancer stigma look like in the UK?
So I've been at the charity for over 7 years now, and I think actually stigma has changed in that time or shifted slightly. I think when I first started, stigma was having a really severe impact on people who didn't fit the profile, and we were seeing that that was severely delaying people's diagnosis. And don't get me wrong, that's still a major issue. We did a recent survey with NHS England, and 14% of people still believe that lung cancer only affects people who smoke. So there's still big mountains to climb, but I think we find ourselves in a position now where we're encountering a division within the disease. We're in the UK, we're starting to hear this phrase, non-smoking lung cancer. And it feels like there's this desire to kind of segment the disease and who it affects. And people are therefore being put into two camps. They're, those who smoked and those who haven't. And it's not overtly stated, but it feels like it's insinuating that there are people who deserve it or deserve it more and people who don't. And for us as a charity, supporting everyone affected, that is not helpful. And in fact, that only fuels stigma further. It feeds those feelings of guilt and shame by someone who has smoked. It potentially widens health inequalities. And it can discourage people with symptoms from seeking help, and potentially denying them a chance of an earlier diagnosis. I mean, for us, it's about balance. Absolutely, we've got to get the message out there that everyone can be affected. If you have lungs, you can get lung cancer, but we can't do it by finger pointing and pointing blame at other people. We need to make sure that we're representing everyone affected by the disease, and that people know that they can come to us for help and support without judgment.
Yeah, I couldn't agree more, and I think it's interesting but not surprising sort of phenomenon, right? That stigma itself is what sort of is driving at least people who never smoked as having a non-smoking lung cancer, for fear that they too will have their finger shaken at them, and that bifurcation of sort of the disease in and of itself is just helping to perpetuate, right? So on one hand, you understand the rationale behind why someone might self-identify that way, and that they aren't understanding that it's just furthering a bigger issue. So what are some of the things that you all are doing out there to help combat that very thing?
So in 2017, we launched our Head High campaign, which was directly aimed at tackling stigma. That message was pretty simple. It was, people with lung cancer should be supported, not judged, and that no one deserves this disease. People shouldn't be made to feel ashamed, and they should hold their head high. That was the point of the campaign, and that was my first campaign at the charity, and it holds a really, really special place in my heart. And it's pretty much laid the foundation for every campaign since. And we're running our Be Unforgettable campaign this Lung Cancer Awareness Month, and that's challenging kind of 3 primary misconceptions: the nihilistic perceptions around the disease, so people having this very fatalistic opinion that it's lung cancer, it's the worst kind of cancer, there's nothing that can be done, so I won't even bother to get that diagnosis because you can't do anything, it's going to kill me. So that's we need to get over that barrier. We need to show people that there are so many more treatment options now. One of the other misconceptions the campaign looks to challenge is symptom confusion, so people expecting to have particular symptoms like a persistent cough, and then of course patient stereotyping, so demonstrating that you don't have to be a certain type of person to get lung cancer, that it really does affect anyone. And we do all this by using real life examples, and we let the people that it affects do the talking. We put them kind of front and center. We don't actually talk about stigma directly anymore, and I know that might sound a bit strange, but the thinking behind that is the more you tell everyone there's a stigma, the more you remind everyone about the potential stigma. So instead, we try and set the example that we want other people to follow. We don't ask our patients about their smoking history, because to us it doesn't matter. It doesn't affect the support we give, and actually we find out if someone hasn't smoked, they tend to tell us that very, very quickly on in sharing their experience. They're much more likely to kind of mention that. I mean, ultimately we're trying to fight against this division, this smoking and non-smoking, and we just want to try and bring people together to overcome it. And for a lot of us, it's very personal. It's personal to me. I lost my dad to the disease, and for us, smoking shouldn't define a person. It doesn't define a person, and we don't want to focus on that. We're trying to rehumanize people that are affected by lung cancer, and the label of smoker, the term smoker, it's not a positive label. It feels like quite a derogatory word. So we try and eradicate that from how we communicate. So we say people who smoke or have smoked, rather than that label of smoker and non-smoker. My dad was a smoker, but he was so much more than that. He was a dedicated and supportive father. He coached football, soccer, to thousands of kids. He loved golf. He played board games with me for hours. So he's so much more than that label of smoker, and that's what we try and get across with our campaigns. And it's been a really momentous year for us in the UK. We've had the announcement for a national screening programme, and this is real progress, and hopefully this helps to start to change people's mindset, because finally people at high risk of lung cancer are being given the opportunity to have the disease caught at the earliest opportunity. And I'm hoping that's telling people that, you know, you matter, and yeah, we need to just lose this stigma now.
Yeah, you know, I love the head high concept and the initiative, and I can hear your passion behind your work. That began, as you said, with that. And it's interesting. At GoTo, when we're in contact with patients day in and day out, like you all are, and that's not a conversation we have either. And you're absolutely right. People who never smoked are pretty quick to self-identify that. You know, in talking about screening, we're thrilled that it's making its way, but screening doesn't come without its own set of challenges that stigma directly sort of relates to. Can you talk a little bit about what you've maybe noticed there, or what some concerns might be, and if you have any thoughts about how to maybe combat that early on?
Well, yeah, that's a huge question, isn't it?
Yeah.
So the smoking screening program that's been approved for the UK, it's for people 55 to 74 with a smoking history, and that could be that they're still smoking now, or that they, you know, smoked 30 years ago. If it's on their medical records, they will be invited for screening, which is fantastic. It's a huge step forward. But obviously, on the other hand, you have people that don't fit into that category. Either they're younger, either they don't have that smoking history, or they're over 74. And that is in itself causing a new set of stigma, because it's, why aren't I eligible for this? Why am I not being given the chance to have my lung cancer caught early? So we are met with a lot of frustration, and I think it's completely understandable, and it's such a sensitive subject that I completely understand why people are having that sort of reaction. I think from our point of view, we see it as the first step forward, and a huge step forward. But it is the first step, and I think we're constantly going to be evolving this screening program. So we funded some research that looked at non-Hodgkin lymphoma survivors, because lung cancer is one of the biggest causes of death within that group of people. That research identified 2 people with, it was only a small project of about 100 people, but it caught 2 lung cancers. So that project is now being expanded on, and there's talk of potentially bringing that into the criteria. So I think it's constantly evolving, and we're seeing a lot of research being done around the impact of air pollution and triggering EGFR mutations. So who knows? I think hopefully this is step one, and we can just continue to evolve and build a screening program that is more inclusive. But every screening program has its criteria. You know, we can't be screening everyone for everything, unfortunately. Breast cancer in the UK is 50 plus. Younger women get breast cancer, but they're not necessarily screened until they're 50. So I think it just seems to have added more fuel to the fire because of that additional criteria of a smoking history.
Yeah, I would agree, and I think to your point, we have to be grateful that we have screening for lung cancer now, right? Although that comes with challenges. We've had it in the US for a long time, yet still, I'm going to give a rough average on the high side, 7% of the people that qualify are actually going out and getting screened. And then on top of that, the adherence to follow-up protocols is also a challenge, right? So I think we have a long way to go, but I, like you, am grateful that it's finally here. Dr. Singh, I think you had a question for Rachel?
It wasn't really a question. I just wanted to echo what she was saying. So the thought of segregating lung cancer among people who have smoked versus those who have not smoked is in a way flawed, not just from the stigma point of view, because you may have people who have had heavy tobacco smoke exposure versus those who have had very little amount of tobacco smoke exposures, and that can fundamentally affect both the molecular profile and the way they end up getting treated. So it's not correct to just segregate them as smoking and non-smoking. Yes, it is very important we document for as our base in our baseline records about the smoking exposure, but we never tell them that the patient, that you have got the disease because you smoked. We never tell them.
Yeah.
I am sure people who have smoked realize that probably they got it because of that, but it is something which is self-realization, and it doesn't have to be really rubbed in. Obviously, people who have smoked a little bit, they tend to behave largely as the people who have never smoked, and therefore trying to just arbitrarily segregate them is not correct.
Yeah, I agree. I think back to my teenage years and even before that, and a couple of U.S.-based organizations were running fairly hit 'em hard anti-smoking campaigns, well-intended, right, to try to encourage people to quit smoking because smoking is bad for a very long list of reasons. But because of sort of the approach that was taken, it had directly sort of embedded in the minds of people everywhere that smoking is what's gonna give you lung cancer. Great, thanks. So Heidi, I want to move on to you. And can you give a brief history of the White Ribbon Project?
Sure. So being a lifelong health enthusiast and health educator and fitness trainer with no known risk factors and no symptoms, I was incidentally diagnosed with stage 3A inoperable lung cancer in October of 2018 and told that I had about 4 to 6 months to live because I was inoperable. Obviously, I'm here now. It's 5 years later, and I benefited off of research, thank goodness, chemoradiation and then durvalumab, so off of the Pacific trial. And I felt very alone initially in this diagnosis, and I didn't know how to find the community. There was no literature about advocacy organizations anywhere where I was treated in infusion lounges or radiation waiting rooms. And I started to approach the healthcare center and the big NCI Cancer Center here in Colorado. What are you going to do for Lung Cancer Awareness Month in November? And I was either getting dismissed or ignored and eventually humiliated with a response. And I thought, why is it okay to communicate or not communicate at all with me just because my cancer happened to originate in my lungs? How dare people talk to me like that? It doesn't matter if I had a smoking history or if I didn't have a smoking history. I love the points you made, Rachel, because we are in total alignment here. And I just thought, well, if I wait for institutional messaging to change or for my cancer center to decide one day they want to do something, I won't be here any longer. So who can stop me from doing something on my own property? And I asked my husband to make me this big white ribbon out of wood because I really wanted to scream to at least my community, whoever walked down my street, that I had lung cancer. Someone in this house had lung cancer. I wasn't ashamed of it, and we need to talk about it. So that sparked a grassroots movement. One picture went a long way on social media, and what I found happening was astonishing. I thought, who's going to want this? It's just me. No one's ready to speak out. But people from all over the country were asking me for ribbons, and we continued to make them. And I said to myself, we'll keep making them because if someone wants something this big, they're ready to talk about it and humanize this disease. And one of the obstacles here is, again, just what Rachel talked about. Yeah, my story is really easy to tell, but we want the people who have smoking histories to be human to those who look at them. So I encourage people to tell their story. You talked about labeling languages. The IASLC put a very good language guide out. And I know it's hard initially, but we need everyone to adopt this language. I can't tell you how many people I meet who are ready to speak out, whether they're patients or caregivers or people who have lost loved ones. And they always describe themselves or their loved one that they lost as, yeah, he was a smoker. And I just said, you know what? He was never a smoker. He was a husband, he was a father, he was whatever he did for a living, and he happened to have a smoking history. That's different than just wiping away the total identity of someone by describing them this way. And here in the United States, we have, these instant sort of medical release of tests and that people get before their doctors even see them. And they'll see, oh my gosh, so-and-so just had a CAT scan, they're reporting the image, and it's like, smoker. That's the first thing they see on there. And they're already feeling, the shame then from the doctor. And gosh, is it that hard to say smoking history or the patient is currently smoking? I mean, this tweak in language is very important. And I have to tell you, we encourage people when they're interviewed. I mean, this is amazing now. My husband's not on the call right now because so many things are happening now in Lung Cancer Awareness Month, and we have to divide and conquer, and we have to decide what we're going to do. And we tell people, oh my gosh, I'm seeing stories, national news stories. There were 5 in October about lung cancer. And so we encourage people, when you have an opportunity to be interviewed by the media, please share this language guard with them, because you could say something in an interview and then the anchors get it and they start labeling people again. I have told people in media when they interview me, if you don't represent me fairly and describe this, I will ask for a retraction of the story. Please. We're in a position now where they want to hear the story. So maybe we can be a little demanding on how those stories are presented.
Yeah, I applaud that so much, Heidi, and particularly, I mean, from people like you, coming from someone who's been diagnosed with lung cancer, who is walking the walk, right? It's easy for me to stand up here based on conversations I've had, but it's so incredibly impactful coming from someone who's actually living with this disease. And the ISLC, and I know in the United States, and I don't know what this looks like around the globe, but in the United States, the advocacy groups in particular have taken to heart, yes, we do need to change to this person-first language. It's not, a patient with lung cancer. It is a person who has been diagnosed with a disease. It is a person who has a smoking history, not a smoker. And really thoughtful way of having these conversations to try to reverse. And I too have seen, small increments, right? It's not happening as fast as we want it to, but the silver lining is that we do see it happen. And I am with you that it's going to take more people living with this disease standing up and talking about, I am a grandmother, I am a mother, I am a neighbor, I'm a friend, right? I'm the person who checked out your groceries at the grocery store today. I am human. So humanizing and messaging, I think, is incredibly, incredibly important.
I really want people to understand, if they question, oh, this sounds like an experiment, it's not going to work. It's like, no, this happened clearly in breast cancer, which was highly stigmatized. I'm old enough to remember women hiding in the house. I'm 60 years old. Mom suddenly disappeared. They were embarrassed. They had double mastectomies. They were ashamed. And HIV/AIDS, that was a stigma. We can't use the word stigma as, okay, therefore we can't do anything to fix this. That community stood up, they made this human, and then you had people of celebrity more comfortable to come out. Originally, they were outed, and this was before HIPAA, and we don't want to have to do that, but the numbers just tell us statistically there have to be famous people out there with this. It can be done. It can be done.
Yeah,
so,
I would agree.
If I may interrupt.
Go ahead, Dr.
If I may interrupt, yeah. So I just want to re-emphasize what Heidi told about the ISLC language, this thing. So it's not uncommon for even us to hear oncologist colleagues telling, oh, the patient failed this treatment. So we have to tell them, no, that is wrong. The patient's disease progressed on this treatment, or this treatment did not work for this patient. It is completely wrong to use this terminology. And I think the ISLC did a wonderful job of coming up with that terminology, because it gives a very wrong message. And as rightly pointed out, if it passes on to the media anchors, and then further out and becomes a norm, it's not correct. So whenever I have the chance, I always tell that, okay, do not use this word patient progressed or patient failed treatment. It's not that. The treatment did not work or the patient's disease progressed despite this treatment, and that is the correct way to use. Similarly, smoker lung cancer patient, no, it's a person who developed lung cancer and had smoking exposure or had history of smoking. That's how to go about it.
And I just want to share our mission statement. I want to make that clear. And, you know, the mission statement was made by survivors and some people in the medical community and some caregivers. And it was established in January of 2021 when we were when we were applying for a nonprofit status. The mission of the White Ribbon Project is to promote and increase lung cancer awareness by changing the public perception of the disease. No one deserves it. And we use the word public perception because we are not changing faces. These are the same faces. We have heard from people in the smoking, community that we don't feel like we're included because you want to change, and it's like, no, we are changing the perception of someone who smokes. We are making you human, real, someone we can all empathize with. So I just wanted to clear that up.
Thanks, Heidi. Rachel, I see your hand up.
Yeah, I just wanted to share a really recent example from the campaign we've just run. So we put a press release out and we're working with the National Health Service and running community engagement events. The media took our press release and edited it. So it was very people with opportunity to learn more about lung cancer. They changed the headline to "Smokers Get a Chance to Learn More About Lung Cancer." So it's the role of the media is perpetuating, and what image do they use alongside it? They use someone with a cigarette, and that is what we're up against. And I also wanted to ask Heidi if we've seen, it's almost like a disproportionate amount of people now who want to share their story who don't have a smoking history compared to those who do. I wanted to know if you also experienced that.
Yeah, that's one of the biggest challenges here. And so we are working hard on that to make people, feel welcome and more comfortable. I mean, I've done that from day one. Yeah. So it's not just about one person. We need collaboration across the board. If you find somebody who is willing to do it and then showcase that, then it makes others, more comfortable. I think we do have a monthly community Zoom called the White Ribbon Project, which is live and it's open to anyone. We're having one this Saturday at 12 p.m. Eastern time. It goes for 1 hour and it gives people the opportunity. We share what's going on, we give hope, but then we open it up. Like, what are questions? What are concerns? People, start to share their stories a little bit, and then we can, already wrap them up in a community of support right on those calls. All are welcome. And that link is on our website, all the time accessible.
Yeah. Thank you all for that conversation around messaging and imagery. I think we could have one entire lung cancer living room about how to try to overcome and combat that. But I do want to be mindful of time, and I do want to get to Lauren. So Lauren, you're up. Same for you. Can you tell us a brief history about your organization, what lung cancer looks like in South Africa, what stigma looks like in South Africa, and what all you guys are doing to try to combat it?
Thank you so much, and thanks for inviting me today, and an interesting conversation with the panel. So Campaigning for Cancer was the first patient advocacy group, cancer advocacy group formed in South Africa in 2008. We started in a fight to get reimbursement for biologic treatments. At that time, it was a breast cancer medication, and then realized that there was no patient advocacy happening on cancer. And because of the disease burden in South Africa, particularly with the high burden of HIV/AIDS and TB, non-communicable diseases and especially cancer were being left out of any policy making decisions. So we started Campaigning for Cancer in 2008, and we work across all cancers, But one of the things that we do specifically look at is the cancers that are underrepresented by civil society. And so we'll look at cancers and focus on cancers where there aren't other patient groups, and that just bizarrely in South Africa is lung cancer. There are no specific lung cancer organizations within the country. So we do a lot of work on that. We've done a lot of work on developing education material with the Department of Health, our National Department of Health, to get it localized and translated, to get them to adopt it into it, as well as advocating for policies. We're currently in the process of trying to develop a lung cancer policy, although there's been funding issues with that. So we're constantly looking at that. If you have to look at the status of lung cancer in South Africa, scarily, lung cancer is the number 2 diagnosed in men, and probably number 3 or 4, it alternates in women, most diagnosed. But the biggest and the most scary statistic for me is in the 2 largest, most populated and economically active provinces, or what would be states in our country. It's the number 1 killer in men. So that's pretty scary, and it speaks to there not being a plan around this disease when it comes to it, and that leads us into what stigma looks like. So we did some work in 2010 with Lance Armstrong Foundation at that stage, and on stigma, and it was just on basic cancer stigma because of the health literacy. A lot of the time cancers are lumped together, and you'll get breast cancer and prostate cancer and cervical cancer and then every other cancer in South Africa. So they'd lumped, and because of the failures in our policy and our access, there's an absolute fear of cancer, and that cancer is a death sentence. That if you're diagnosed with cancer, that it's painful and that you will be in pain. So we have that on to deal with from a stigma point of view. Also, South Africa was a signatory to the framework, the smoking framework, and so we've had for a long time, was most of my lifetime, we've had pretty good preventative tobacco cessation messaging and so on. But at the same time, it's created that stigma of what everyone's been speaking about. So we've seen that as well. So it's kind of like the symptoms on that. And then we have these other diseases that are put into play where you have to choose between HIV, TB, and lung cancer. And it's actually better because there's treatment and access, it's better and more acceptable to be diagnosed with TB or lung or HIV than it is lung cancer in some places in South Africa. So that's like where the systemic and policy issues have led us down in South Africa when it comes to stigma. And then we have a cultural stigma that also happens, where within certain communities, because of the myths that exist within those communities around diseases that they don't understand and literacy on that, there are myths that exist. So things like cancer is contagious. If you go and have treatment, or if the air, when you have an operation, the air touches the cancer, then the cancer will expand and grow. Also, that if a part of your body is removed, you will not be accepted into heaven. And then again, that if you are diagnosed with cancer, you are bewitched. You've been bewitched by someone. So that diagnosis is because someone cursed you, and that curse was put on. So that's the basic realms of stigma that happens. The most significant, specifically related to cancer, to lung cancer, is the smoking versus non-smoking history. that would be that. However, in South Africa, we have, we have a very big population of mining and asbestos mining and that. So things like mesothelioma is very, very, very prevalent in South Africa and that. So, not even that has overshadowed the idea of smoking because of the tobacco cessation messaging that was initially came out in that. So that's a little bit of the profile with regards to stigma.
Yeah, it's interesting, and I couldn't agree more that there are sort of two arms to this, right? There are systemic issues and challenges that help perpetuate stigma, but I love the fact that you touched on some of the cultural beliefs that also are directly sort of affecting outcomes for people diagnosed, and I think that's an even, well, in my opinion, but I'd love to hear others' thoughts on it. My view on that, at least my knee-jerk reaction, is that almost feels like a harder nut to crack, right? Because these are beliefs that are embedded in these people for their entire lives, and to ask them to come outside of that belief system, I wouldn't even know how to touch that. I don't know if anyone has a
so we've done quite a bit of work with that, and in the past, so in South Africa, almost between 70 and 80% of people will consult a traditional healer or traditional health practitioner before they even go to Western medicine. And in the past, we were seeing that those traditional health practitioners were holding on to the patients. And when we started to work with them and to understand what that was, and it was actually an easier nut to crack than we thought, because it came down to, well, you're taking my clients away from me, and that Western medicine doesn't see the benefit of the spiritual journey that I go through with my clients. And we started to then educate the traditional health practitioners on cancer, and for them to understand that, and them to understand and to admit that they couldn't cure cancer, and then begin to do the talking and the liaison between the Western medicine and the traditional medicine to try and get them to understand that there's a role between both of those and that there's a common ground to be filled. So we've seen that work quite well. We're not all there yet, but it's definitely been eye-opening on both sides of the camp.
Rachel?
Yeah, we did something similar. So with the lung cancer screening pilots, so they're dotted around the UK, well, England at the moment, there's not a full rollout. And we've worked with kind of mosques and faith leaders and got them to almost endorse and buy in and support the program and communicate that to their communities. So it's trying to give it the green light within those communities as well, which I think is similar to what Lauren was saying.
Yeah, and those types of, yeah, and I think in the US we've worked in that space as well. I'm thinking more along the lines of someone whose belief system is either not to take any medication at all, not to remove any body parts for fear of not getting into heaven. Those feel like sort of these insurmountable sort of, how do you approach that?
We've done specific campaigns on myth busting. So trying to educate and do that health literacy in a way that's culturally sensitive and on that. So that's one of the things, is putting as many facts out as possible, so that when that is there is there are resources for whoever's going against that information to provide that agency for them to argue their point.
Yeah. Lauren, before we move on to sort of all of us and some sort of final thoughts about this, is there anything else you want to share with how your organization is working towards combating this stigma?
So we've looked at the solution. Number one is on a policy point of view, and we do this through two ways. We've created patient advisory boards and mapped out patient journeys, and then taken those patient journeys to decision makers to showcase to them where that stigma and where those problems are doing it. So to sensitize them, obviously. We've also looked at, the work on expanding access to treatment and making sure that there is that, so it's not seen as a thing. The treatment is very basic that patients receive in South Africa. And then we've created think tanks through multiple stakeholders to come up with solutions. We're busy looking at creating that for next year, trying and advocate that there's integration into the TB programs that are running, that are significantly funded by PEPFAR and USAID, that have for HIV and TB, that have actually created like siloed health systems where you can't access, where we have people being screened for TB and then picking up a lung cancer and not being able to refer the patient on. So, educating on that point of view. And then we have our patient advocate incubator, which is an online learning platform to try and provide information available to patient advocates, as I said, and educate them as much, and giving them a resource and a library where they can find credible information, as well as educate themselves and get some capacity building.
Yeah, I think that's great. And I think we've had a lot of conversations, and each of you, some of the things that are sort of bubbling to the surface about, around solutions, and some of us are doing some of this, but things to continue to think about around educating people diagnosed, empowering them to be their own advocates, to share their stories, to be a face behind or in front, I guess, of the diagnosis, messaging, imagery, continuing to, look towards solutions for systemic and cultural influences that might be attributing to the stigma, including this myth-busting thing. But I want to go around the horn one more time. There's Pierre, before we close out, and just say if there was one thing, and I know this is an impossible question, but if there was one thing that you would like people watching today to take away from this conversation, what would that be? And we'll start in the order we kind of came through. Dr. Singh, I'll start with you.
So to summarize, the message which should go across is that it is not necessary to have smoking exposure to get lung cancer, and basically what everybody has been saying these days, anybody with lungs can get lung cancer. And number two is, with the increasing advances for both diagnostics and therapeutics, it is important to consult a treating clinician or an oncologist who is well aware of what can be done in the best possible manner, including doing biomarker testing wherever feasible and offering the appropriate targeted or immunotherapy based upon those results.
Great, thank you so much. Rachel, how about you?
I think it's just about people. I think we've said this repeatedly. It's losing these labels. It's not focusing too much on smoking history, but in the same breath, not deliberately ignoring it, which I actually think we had a phase of doing. We were so determined that smoking history didn't matter that we just sidestepped it, and I think that felt like we were trying to hide away from it as well. So I think, if we can find people, and it is about balance, isn't it? It's about having that full representation of people who are affected, who are comfortable talking about all the different aspects.
Thanks, Rachel. Heidi?
I would echo that completely, but also in a general sense, you know, we've been attacking lung cancer kind of backwards. We've been trying to grow little bits of awareness about this and that and the other, but where was the general awareness that everybody should be concerned that they could get it? And then there is hope is very important. And why is it so hard to normalize this particular cancer? Can we just look at it in very simple terms? The general public, at least in the United States, and physicians and specialists believe that any cancer can spontaneously generate from any organ, and we just don't know why. But for some reason, the lungs are the only organ in the body that could only generate a cancer if it gets a tobacco product. I mean, that's the messaging. So if anyone can get it, and we have the medical community validating that, it gets on people's radar, it becomes more normal. It's a cancer everyone wants to be screened for. With enough public demand, maybe more increased funding across the board, right? For a better detection method, research funding for better treatments, and now this whole new issue in lung cancer survivorship. So I know that's a lot, but it's important to try to talk about this cancer like it's another cancer, any other one.
And Lauren, is she back? She did mention, oh, yep. No, she's not back. That's me. I'm looking at myself. Lauren did mention that there was going to be a scheduled power outage, and of course it happened during this meeting. But what I do want to say is, outside of a huge thank you to all of you for coming and having this conversation today, and you know, the Elcam Coalition, and for being a part of the Elcam Coalition. For those of you who may not know, it's a global coalition that's been pulled together to be, show a united front around generating awareness for people diagnosed with lung cancer. And I think this is a beautiful example of how we can come together and have these conversations, not only during November, but continued conversations throughout the year. So thank you all so much. I look forward to continuing conversations like this and others as we move into and through 2024. A couple of housekeeping items. Our next lung cancer living room is December 19th. Our topic is our year of hope. So we're going to go through all the amazing things that have happened in lung cancer in this past year alone. It's that time of year again, so we'll also have our little holiday party for those who are able to come and join us live. Gathering Hope is December 12th. Anybody who's interested, hasn't participated, is interested in participating in that really that peer-to-peer conversation and roundtable, please just reach out. A huge thank you again to our panelists, to the Global Elcam Coalition, all of you watching live or post-live, Onyx and Ash, Penn Media for coming in and helping this look seamless, because we know it is not. Michelle Zay, who as always is over here in the corner moderating the online chat, the entire GoTo team for helping to pull this together. Our supporters, we would not be here without our supporters, so a huge thank you to Amgen, AstraZeneca, Bristol Myers Squibb, Daiichi Sankyo, Eisai Foundation Medicine, Genentech, Gilead, Janssen Oncology, Merck, Mirati Therapeutics, Novocure, Novartis, Regeneron, Sanofi, and Takeda. And that's a long list, like I always say, of people who really believe in what we are doing here, what you all are doing out there, and enabling us to bring this type of information to our community. So thank you all, and we hope to see you next month.
So I'll be brave if you're brave. I'll be brave, but only if you're